And we're recording. And okay, so I'm calling this neuroplasticity after brain injury. Neuroplasticity is the brain's ability to adapt and learn.
We don't see the, speaker view.
Does that
That's
help?
better, that's perfect, thank you.
Okay, thank you. I'm gonna have to shift in and out of this a few times, but that's okay. So neuroplasticity after brain injury. Neuroplasticity is the ability of the brain to adapt and to learn. However, relearning after brain injury is not the same as learning. For anyone with a brain injury, I believe we are aware of this. Promoting and using neuroplasticity to improve after brain injury is a difficult process and requires many factors to be considered and supported over time. And I just want to say that I have not found research that helps me think about this. I use my brain injury and my observation of other brain injured people to make better sense of this. And my brain injury happened in 1999. I was in the backseat of my friend's car that flipped. I had a subdural hematoma. My head was kind of crushed, and well, my head was crushed, and my skull was removed to relieve the brain pressure. It took me about 7 to 11 years to rebuild most of what I lost. And I get into all of that stuff, the visual problems, the cognition, memory, depersonalization, derealization, and many other problems in this talk that I put out in this talk series called The Bizarreness with Brain Injury. So if you're interested in that, I have that in other places, but I learned how to rebuild, regain, and redevelop what I had lost. And towards the end of my undergrad, I got into neuroscience. I did my PhD in neuroscience, and I did a postdoc for a few years. But really, it was always about trying to make sense of what happened to myself after my brain injury. So that's where I come at this from. Everything I regained, I relearned, I rebuilt, and I redeveloped came from work and effort to regain what I had lost. And also learning to not push myself to my limits, which had great value in the brain injury recovery. I didn't sort of realize that until about 3, 4 years into the process. So the process of neuroplasticity happened within this, and it happened in slow stages that repeated in patterns that it took me some years to become aware of that. And I have now a podcast called Experiencing My Brain, and this talk series, the Building Brain Awareness to Help Support Brain Injury Recovery, or BBA for short, interviewing brain injured people to get at their problems and interviewing the clinicians, researchers, experts at what they know about brain injury and brain topics. So I've been working hard to capture these examples, really to fight the misunderstanding that surrounds brain injury. And in this talk and in the talk I just did, I'm going to be referencing these examples as more as the evidence. There is research out there, but I still think like they're missing certain pieces. So, four critical aspects involved in neuroplasticity following brain injury. Number one, there's a reality of the effort. Functioning after brain injury is very challenging, especially when it comes to brain injury problems. And it takes considerable effort and repetition before anything can feel easier. There's a huge psychological toll with brain injury and with the promoting of neuroplasticity following brain injury. Frustration, confusion, self doubt, self judgment, guilt, shame, and just feeling hopelessness are emotions that are a part of this, journey. And, a lot of it is you're trying to do what other people consider easy or automatic, and it just makes it very challenging. Plus, the emotions are compounded by others around us judging and misunderstanding these invisible struggles. A very important point is that effort drives neuroplasticity. So while neuroplasticity is a property of the brain, it's very complex and studied, it does not occur, at least in my experience and observation of others, without the effort, the repetition, and the focused rehabilitation if you can find it. Time. Improving brain injury takes a long time, in the scale of months and years. Many individuals may feel discouraged by this slow process, and it's necessary to find a way to reinforce the continued effort, have the motivation, the necessary support, and also, the long-term nature of this needs to be recognized by the people around us and by the professionals around us. And I haven't really found that to be the case. But I think that they are learning, and there are some good experts out there, good clinicians and good therapists. So I see three invisible realms of brain injury, and the promoting of neuroplasticity needs to happen within all these realms. There's the work to improve, and that's symbolized here by this stairs, going up. And that's the work to rebuild and regain. There's also setbacks. If anyone has had a brain injury, they know about setbacks happening. We're going to get into that in some detail. And also the downward spirals that happen with brain injury. All of these involve both neuroplasticity and learning to not make things worse. So, what is the common view of brain injury symptoms? I took this recently off of the BIA website, and there are many similar, tables like this out there. There are physical, cognitive, emotional, and behavioral symptoms, but the outside world is gaining better awareness slowly of brain injury problems, but they still see the symptoms, only within a certain context. There's a lack of awareness, lack of how these problems are unique because they look like other problems that are common in other disorders, but I think the brain injury problems are different. And brain injury problems interact with each other and aggravate one another. They also come with the fatigue. So it's kind of a different can of worms. I recently gave this talk. I call it the capturing of puzzle pieces of the invisible. And there's invisible problems with brain injury. They have these common layers. The common layers being the core problems, the fatigue, the psychological, emotional, and trauma responses, the gaining awareness of your own problems to make sense of what has been injured, and then the misunderstanding that is the outside world's inability to get what we're dealing with. Like I said, I just gave this talk and I'm going to put it out on YouTube this week. I've been working on cleaning it up to share. I see these different and these common 5 invisible layers, and I call these the parallels of brain injury. And this is just a quick summary. So the core problems are the invisible problems underneath the other visible problems that the world sees. Often there are multiple core problems each brain injured person has to deal with, and these problems interact and aggravate one another and can lead to other problems in our lives. There's the fatigue, which is there's many forms of it, but the brain fog, the absolute mental, physical exhaustion, and all of these make brain injury and life much worse. There's the psychological, emotional, and trauma responses that are often accurate and I think appropriate given the problems that brain injury puts us in and the situations each person is in. Also, these emotional and psychological capacities can be injured. So you can have brain injury to those capacities, and then that needs to be looked at as a core brain injury problem. The other layer is awareness of one's brain injury problems that can be accurate. And the capacity for awareness, alternatively, can be injured. That's the anosognosia that Jared had just spoken about. And he gave a really good talk in my series, if you all want to check it out. So the last layer is the misunderstanding, which I believe we all know is the general judgment, misunderstanding, and misconstruing of brain injury problems, which is a huge problem that is on top of the brain injury problems. So here is an example that I have recorded in one of the talks in my series. Dr. Karen McAvoy, she's a PsyD. She works at a clinic and she's worked in schools, but she's built stuff at a state and national level that helps educate brain injury. And she gave a really good talk. And I see this as a great example of the invisible problems underneath other brain injury problems. For those of you who were at my last talk, I did show this, but I need to show it again because it's the best example I have.
Let me introduce this model to you. Okay, so this is a model that we came up with at the Colorado Department of Education. The reason we have come up with this is because we as clinicians, we as school providers, we didn't want to get into this, what happens in the world of brain injury, which is, you need to be a neurologist to know the brain. You need to be a neuropsychologist to know the brain. This myth that there's only a few people out there and few disciplines out there who know the brain well enough to help people who have suffered a brain injury. And we as educators, we have, kids who suffer brain injuries all the time. And now I work in a clinic where we have adults who suffer brain injuries all the time. And this sort of myth of if you're not of that discipline, you can't be helpful to these people. And we did not like that. We wanted to be helpful. We had to get away a little bit from the idea that we need to know exactly where in the brain the injury is, and then, only a certain person can fix that. What we tried to do with this model is to make this much more person-friendly, educator-friendly, parent-friendly, so that we all can jump in and support anybody with a brain injury, because these are skills we all know how to support. Let me start first with just explaining this model. the brain basically develops in this bottom up model. The things that develop in infancy and childhood are going to be what we call the fundamental skills, which are memory, processing speed, attention, inhibition, which is the ability to stop long enough and make a better choice, and sensory motor. So if you think of young children, this is what they're working on in the beginning. Eventually, when they become toddlers, they're, learning to wait. If they're hungry, they're crying, but, they have to wait until the bottle gets warmed up, that kind of thing. And so these fundamental skills develop first in a brain. And then eventually what builds on top of that are things like going to school, learning language, learning reading, writing, and math, and visual processes. So you can see the second green level is what we call the intermediate processes. What builds on top of that are what the blue level, which we call higher order processes, which is social emotional competency, being able to know when it's okay to tell a white lie, manners, being polite, all of those things. And then executive functioning is the other thing here, which those are many of the things I think you had a speaker talk about earlier. That's like organization, planning, initiation, problem solving, judgment. Those are the things that really lead into our personality. Those are the higher order things that tend to kind of come from the frontal lobe, but they have to do with how well are we managing life in a social, emotional, multitasking way. And then finally, on top of all that is the person who is just well put together. It's achievement, it's their job, it's how they do at school. And if everything underneath is pretty well put together in the brain, and there's been no injury, this is how the brain develops. And this is a pretty well functioning person. So this is the model that we go with now. But what happens is with a brain injury, if one area gets knocked out of place, and you probably all know that attention is probably one of the most common things that gets knocked out of place, whether that's with a 3-week concussion or a 36-year brain injury. These fundamental skills are the first things that get knocked out of place. What happens to the rest of the skills on top of it? They fall in, they collapse in. So learning might be harder for a child who had a brain injury. Language might be harder. But what really people come to us all the time saying is that this person's personality is not the same. This person's not making good choices with social emotional things. They're, asking me inappropriate questions. This person doesn't have executive functioning, meaning they're not organizing as well. They're not multitasking as well. They're not functioning as well. They don't have as good judgment. And they'll come to me as a psychologist or some of my colleagues and say, this person with a brain injury has these issues. Everything looks fine with them in terms of cognition, in terms of, an IQ score or something. Yet we have these skills that are not working so well for them on the social emotional executive function part. And then they say, fix those, make that person stop asking that question, make that person, behave better, especially with kids. I get a lot of this, make that child behave better. And that's the reason why I love this model, is because we now know as educators, and I know as a clinician now, when someone says to me, make their executive functions better or make their behavior better, I don't go straight to try to fix executive functioning. What I look at is, where is the deficit that I can fix and work on? And that's what we work on cognitive rehab.
Wow, that was good to see again.
Yeah, and so that is, I have almost 2 hours recorded with her. I narrowed it down. I'm going to use several examples like that throughout this talk. Although she's speaking about cognition alone, for example, in this series, Dr. Jared Brown, Jared that just presented, he's spoken about the sleep problems, confabulation, and anosognosia, and he gives these comprehensive descriptions about what can be underlying, what is the root cause of these problems. And I think that's the nature of brain injury problems, because we get so many of the things that are underneath the other problems injured. And so I think that's a common property of brain injury. And getting the right help for the core problems, the root causes is really where the right help and our needs get met. Anyway, he gives some really good examples in these talks, and so going back to these invisible realms of brain injury problems, the work to improve, the setbacks, and the downward spirals. So we're going to start with a closer look at the downward spirals with brain injury. And the downward spirals, they come from the brain injury problems, plus the fatigue, plus being pushed to or beyond one's limits, and also the visible problems, meaning what the outside world kind of expects of us. I'm speaking about the invisible, but there's the need to work, the need to drive, the need to go to a doctor, go to a clinician. That list is endless. When these things are in combination, it just makes matters worse. And so I see two subcategories of downward spirals: the invisible gauntlet, and I know I'm making up these terms, but I think they're valuable, and the invisible quicksand. The invisible gauntlet is when invisible barriers present themselves as a task or goal is being attempted, and the invisible quicksand is when brain injured people are just trying to, basically, we're overwhelmed in a way that makes doing nothing or just trying to exist not possible. And I have a few examples of these. So the first is the invisible gauntlet is barriers present themselves when we're trying to attempt a task, and the task is often easy or automatic. One good example is in episode 9 on my podcast. So I'm going to share audio here.
If I'm in the kitchen and I'm trying to cook dinner, I'm thinking about, okay, I need to cut an onion. The onions are over there. The cutting board is over there. The knife is there. And I'm reading a recipe. And there's a lot of places I have to go.
Yeah.
A lot of head movement.
Mm-hmm.
And it's a lot of memory stuff.
Mm-hmm.
And it is very challenging. And the worst thing they could do at that time would be to come into the kitchen and try to move around. So I'm trying to make soup, and I'm looking for the onion, and I'm going over here to get the knife, and I'm getting the chopping board. And they're like crossing behind me, getting things out of cabinets.
Yeah.
And they know that this provokes symptoms, but they have forgotten.
So then how did you deal with that? Or what happened?
So I put up all over the house, like 10 different sheets of paper that said, I have a brain injury. And I taped them all over the house.
How does that equal they need to not do what they think?
They see it. And so now for at least 6 months,
Mm-hmm.
on our refrigerator is an 8.5 by 11 piece of paper that says, I have a brain injury.
Yeah.
So if they start to come in to the kitchen, they see that sign, and it reminds them that I'm struggling.
I think that this is a great example, and I'm going to go a little bit off script and just say that in my experience, the work to improve meant I'm going to practice making the soup. I'm going to get the onion, get the knife, get the basics, and repeat it over and over again. And I did that kind of work with a lot of things for years, but I just wanted to share that. Another example, and this is another term, invisible quicksand, meaning invisible quicksand when a brain injury problem is overwhelming in a way that makes doing nothing and just trying to exist not possible. And since the slide shows up now, I'll share. Nancy, you're here. I want to use your quote for invisible quicksand: the reality that there is no stable foundation. You may go down at any moment without warning, and those around you may not see it or believe it. And I'm going to share an example from the podcast with Patrick, but Patrick's problems with brain injury are different than Nancy's and different than mine. And all of us, at least I think, can think about this invisible quicksand. Shifting screens.
But I could immediately tell like something is wrong and you need to watch out for these physical changes coming thereafter.
Do you rest, or what do you do at that point?
Typically, no. It's a tidal wave. You can build yourself a little sand castle to try to, stop the water from hitting you immediately, but there's nothing that you can do. I've been improving a lot since my most recent setbacks. I'm not motion sick all the time, which is good. Yeah, and I was having like pretty significant eye strain and light sensitivities. These are kind of my new prism lenses, and those seem to make a huge difference. I wear them like 24 hours a day, and if I stop wearing them for more than like 20 or 30 minutes, my headaches come back. I start to get sick. It's really strange. So I feel like I've been
What was that vertigo, or whatever you want to call it? What was that like?
The glasses made a big difference. Basically, I had received these lenses like 3 days before I got hit in the face again and was back to, visual tracers and being nauseous all the time. And it's like I was on a sailboat and I could never get off 24 hours a day.
The point being that these brain injury problems can manifest in a way that makes just existing very difficult. And very recently, I had a really good talk in this series. Julie Stutz from Sensory Learning, an institute, she talked about auditory, visual, vestibular problems. And I think these problems drastically can underlie and aggravate so many other brain injury problems. But there are many examples of these kinds of brain injury problems. The next topic, setbacks with brain injury. So setbacks put a brain injured person in a much worse place. Setbacks with brain injury are unexpected problems that happen, and it could be a bump to the head. It could be being forced to push beyond one's limit, maybe trying an alcoholic drink at a party or at a wedding, or other forms of stress. And this, I think, dovetails well with what Jared had just presented. But these things can really aggravate and bring on new brain injury problems or make the existing problems much worse. I used to call these the trap doors because I would hit them and set me back for, days or weeks at a time. But this is a major problem with brain injury. And I see neuroplasticity in the context of not making things worse. I'm just going to read this slide. With the downward spirals and the setbacks, these brain injury problems require the right help, support, structure, and for others to believe what we're dealing with. But that's not always available. Brain injury people I've met have very specific invisible problems that often lead to these types of categories. And neuroplasticity is involved in improving or learning how to not make things worse. In many cases, the right treatment is necessary, especially problems with visual, vestibular, pain, and migraines. I know that the example here, Patrick, he shared that if he didn't find the Mind Eye Institute in Chicago and they gave him the right lenses, I don't know what he would have done for his vestibular issues. But in some cases, a person cannot find the right help, and in which case, the right strategies to manage and improve the problems, that's all we're left with, which is a sad but true situation. So I think learning how to build in a step-by-step manner may be possible, and it's always better to find the right help. I'm going to give some more examples on that. Given all that, now we can talk about the work to improve brain injury problems. So the work to improve brain injury problems, or core problems as I call it, is what drives neuroplasticity. And every single step of it can feel very difficult, can feel impossible. This level of difficulty remains for a long time on the scale of sometimes weeks and months and even years. But in my experience and observation of others, I think that improvement eventually happens. And here's a really good quote from Jamie Mo Crazy. She's a brain injury survivor. She has her own podcast on this stuff. But here is her discussing this in my podcast.
With a brain injury, your brain is covered in a giant snowstorm. And the first time you walk a path, like when you walk past it through snow up to your neck, it's almost impossible. Like it's so close to feeling impossible to walk that path that it seems so much easier just to give up before you even start. So like the right side of my body was paralyzed. And when I was in the hospital, my mom actually started taping down my strong hand so I would utilize my weak hand at intervals of time to help regain those synaptic connections. And quite often the family caregivers and the survivor themselves would say, because when I left the hospital, I couldn't hold water without my hand shaking.
Yeah.
Well, hold it in your left hand. Cut with your left hand if that's your strong hand. Cut with your strong hand and just don't use your weak hand. And if I hadn't used my weak hand, I never would have rebuilt those brain pathways to now my sides of my body work equally to each other. Going back to that snowstorm and those brain pathways is the first time you walk that path, almost impossible. The second time you walk that path, almost impossible. Third time, almost impossible. It's not until like the 100th time you walk that path that you begin to see a change.
I think she says it very well, and that was my experience too with most of the things that I tried to do. It felt impossible. It was so hard to do. And here's another example that's something more subtle, or an example that with brain injury, what gets injured is often not, well, I think this quote speaks for itself.
Hey, I'm gonna, listen to it for 5 minutes and then 10 minutes. And then I started having tasks of listening to music while doing another task, like while writing down numbers or sorting pennies, or something which sounds mundane, but having to do that while listening to music. In the beginning, it was like extremely hard.
Yeah,
I couldn't, I think most people don't even realize how amazing it is that your brain can just put something in the background without you even thinking about it. It's like, all right, I'm listening to music. Now somebody's talking to me. I'm going to put that music in the background. And I just couldn't do that. It was, everything had equal weight and it was entirely overwhelming.
Yes.
And so I actually used to have a mantra that I would say, all right, you're in the car and my partner, John, he's talking to me and the music is playing. And I would say, put the music in the background. Put the music in the background.
Oh, wow.
And I would repeat that to myself, as I started to as I was being taught why this was happening. And eventually I could, but first I had to actually tell myself.
That example is from a discussion with a woman named Jenna, but she's explaining a very similar process to what Jamie had described. I have a few other recordings where this kind of slow work to rebuild and regain is discussed. Hand in hand with that comes with the psychological challenges that come, with both brain injury problems and also the work to improve. So in addition to every step being so challenging, there's also the frustration, confusion, self-doubt, self-judgment, guilt, shame, anxiety, and just feeling, super hopeless about it, like you're stuck in a hole that people don't understand. So these psychological issues, as I explained, are only made worse by the outside world not understanding what we're dealing with. So in another recording I have with Melanie, she had drastic brain injury problems plus the misunderstanding and inability to find support.
I felt like I was always a foot behind my body. And I just felt like I wasn't in the real world. I had developed some trouble speaking. I couldn't see. I couldn't follow conversations. It was hard for me to get a glass of water because I would have the glass in my hand, but I just couldn't think of how to get the water in there.
Right.
I would try and make oatmeal in the microwave, and I couldn't remember how to make the packet into oatmeal. And it was very like, I'm a woman in my 40s, like I've been doing this my whole life. Like all of a sudden, I can't do this stuff. And my primary care was just telling me that I was lazy and it was all in my head. And she sent me to a psychologist because she said I had PTSD from my car accident. And within the first 2 minutes of my appointment with the psychologist, which took me like another month to get that appointment, the psychologist said, very clear that you have traumatic brain injury, and why didn't doctor send you right to a trauma center or someplace? So she actually was the one, she put me in touch with the Cantu Concussion Center, and I started seeing them. And that was the first point where they said, like, yeah, you have a pretty bad brain injury. And just hearing that was just like this feeling of relief for me, because my primary care had been just telling me that I was lazy. And I believe, like, I was just like, well, I'm not trying hard enough. I definitely did develop depression, and I definitely was having thoughts of suicide. I think the big part of it was just everyone just thought that I was just doing this to be difficult, or that I was just doing it to be lazy, feeling like hopeless. And once I went to the concussion center, and actually once I saw the psychologist who said, you may have PTSD, but you definitely have a traumatic brain injury and you need to be in treatment. That was kind of a turning point for me, where all of a sudden I was like, someone's going to help me, because I didn't know what to do, because I didn't really know what was wrong, and I didn't know why I couldn't do the things that I was supposed to be doing. But when I started treatment at the concussion center, every time I would meet with the case manager, the first question was always, have you had thoughts of suicide?
One reason I choose to use that example is because I think I've discussed suicide with every single brain injury person I've ever spoken to, in one form or another. And these examples are long, but brain injury is complex, and that's why it's like we need to get into this in a way that represents the brain injury part. Another example I have of the work to rebuild and regain. I have almost 2 hours recorded with this guy, Steve, but I narrowed it down. But it's really fascinating. So Steve was a former British Special Forces, soldier and instructor, and he developed a neurodevelopmental based treatment to restore the factory settings of soldiers. This was a thing he did before his brain tumor and before his stroke. And the idea, well, he'll explain it in the excerpt that I have here. But after his recovery from his brain tumor and stroke that was on his brainstem that affected his movement, as well as other problems, he used this developmental based approach, and he's helped hundreds of brain injured people. He's built this online free resource to learn how to rebuild. It's called the Brain Injury Movement Rehab. Although he's talking about movement, the examples that he gives, in an overarching way, fit brain injury overall, and that I can share that what Steve describes, the development of movement and relearning based on a hierarchy of dependencies, meaning each stage needs to build off of competency of a lower stage. This framework, in my experience from my rebuilding of cognition, I would regularly overshoot my abilities, and I would hit this overwhelm and fatigue and super frustration, and I'd have to fall back to the level that I had regained or built competency of. And this pattern happened to me for years and years as I rebuilt thinking and just, my what I call was my mind. But it translated for me into this baby step and baby step approach. But I think that the way he describes it actually is very helpful. So I'm going to play. This will be the last clip I have.
It's about the classic approach to movement rehabilitation following brain injury, and why that has such poor outcomes. And then I'm going to use both the story of my own experience and the work I've been doing with something called the Movement Project. I had a cavernoma, and it was on my brainstem. And the cavernoma bled and caused a hemorrhagic stroke. As a result of my hemorrhagic stroke, I lost the ability to walk. Speech and swallowing were compromised. I had coughing fits that had twice left me unconscious. After the stroke, I couldn't walk, but after the surgery, I couldn't even crawl. The hemiplegia symptoms I had were now bilateral, and double vision was constant. My reflexive stability was so poor that whenever I tried to self-support, I could actually feel gravity. I did 2 years with the Airborne, and then 12 years Special Forces.
Right.
And then it was within the Special Forces where I found out about the work of Greg Cook and functional movement systems. And I really invested in all of their philosophies. It was those philosophies which I then used to drive my own recovery. I discussed with the doctors and the physios as to what they planned for my recovery. And I completely disagreed with them. It just totally went against all of my knowledge and my beliefs about movement and movement quality, and also how it can be taught, and also how it can be restored. UK Special Forces physical test, the physical selection to get in, extremely demanding. At the time when I was there, the pass rate varied between 0 and 1%. It's supposed to be hard, but it's unsustainable for it to be that hard. And the reason why these recruits were failing, it was because of injury, essentially chronic sports injuries, knee problems, ankle problems, lower back problems, iliotibial band syndrome. So what we thought, right, we've got to get them back to factory settings. So we said, well, how do we do that? Well, movement's got a hierarchy of dependencies. You can't exhibit any one skill if there's an absence in the skills it depends on. And we learn these skills as infants, as babies. And so we thought, if we're going to reset all of these guys back to factory settings, let's get them rolling, let's get them crawling, let's get them squatting. And then we changed at 0 to 1% pass rate to over a 50% pass rate. And we were consistent with that. That was where all of my founding beliefs and philosophies about movement came. And so when I had all of my movement skills robbed off me, I knew exactly what I was going to do to reinstate them. I was at first, surprised, then borderline amazed and disappointed. The establishment doctors and physios just thought the complete opposite. That the first thing they were trying to do was to teach me how to walk. What about all of the skills that walking depends on? The accepted belief is that once a brain injury patient is 3 to 6 months post-injury, no significant improvement is possible. It's as if it's believed that's a limitation of the brain's ability to learn. They're immediately taken to what they call compensation strategies, ways to work around their deficits. And a phrase which I have to be honest, I detest is people learning to live with their new normal. And it's clear how that can be helpful. However, with that comes almost like a level of that you need to have a level of acceptance. Neuroplasticity, which is the brain's ability to learn and develop new skills, basically. That's there for life. I found myself out of hospital, still in a wheelchair. I would be better off at home crawling around on the floor than I will in a high-sided hospital bed where, it's difficult to move, difficult to get out. And so that's what I did. If I was in the living room and I wanted the television controls, I would crawl over to the controls. Now, what this also does, like when a baby is learning its developmental skills, it doesn't sneak off to the gym when its parents are asleep. It lives its movement education.
Wasn't it frustrating though when you're trying to do the thing that you thought you can do, and then there's a psychological aspect to it because it's like I should be able to do this.
One of the things was there is because of my backstory and my experience with developmental movement patterns. I would only try movements where I had competence in the dependent skills. This is a lady called Amber. She was either 12 or 14 years post her first brain injury. She'd had 5 hemorrhagic strokes and she'd had 3 brain surgeries. And this is where Amber's just going to try to kneel up, and her movement challenges are quite visible.
Yep. Okay. So I go back.
And all she's trying to do here is just kneel up. 3 months in. And you can still see that a movement is really challenged. But I think it should also be quite evident where the amount of learning that's going on. This is within the zone of proximal development. 10 months on.
Really? Good.
Or 20 months after that first video you saw where she couldn't even kneel up, which was 14 years on from when she'd been told she's got all the recovery she's ever going to get. And you can see she's doing a walking drill here. She's not just trying to walk, so she's lifting her knees up so she could actually walk. What I feel are the contributors to the established protocols having such poor outcomes. Going straight to walking. Walking has dependent skills. And you can't build a 10-story building and start at the 6th floor. And so if you're going to go through the neural development sequence, which is pretty much the milestones that the baby goes through, and I say that there's really good physical and neurological reasons why you need to go through those milestones. You get your competencies in place, and that is how you build a complex skill.
I really like that example. The thing about what Steve has done is that he's done this with hundreds of people. His focus is on movement, but I believe what he's explaining can be applied to many other problems that get injured. For me, it fits what I did with my relearning of thought. I have another really interesting podcast that I couldn't find an excerpt from, but this woman, Linda, she has a blog. It's called The Brain Fairy, Living with Brain Injury and it's about the unique details of brain injury. But she describes a process, a 17-year process of rebuilding and dealing with her problems in stages. And she experienced, it's a tour de force of finding the right therapies or trying again and again to improve on her own. And she has this, hierarchy of brain injury problems where certain things were more dominant than others. The visual problems, I can't remember all of it, but she had to deal with certain things in stages to then be able to deal with other things later. And she describes stirring up of brain injury problems, meaning how they would aggravate one another, and the importance of not pushing herself to the limit. And she learned how to work in these tiny efforts. And she's one of the only people I've spoken to where the cognitive work, the rebuilding of thinking, it really reminds me of what I had done. And pretty much, I had some help for the first few months, but it was kind of on my own. And she was the same with it. She rebuilt all she lost and kind of on her own. So, for anyone interested, that's a really good episode 24. I would suggest you check it out. This is a figure I just made, but I have a number of discussions with brain injured people about this kind of slowly rebuilding, regaining, and I just listed those up top. But these are all examples of this effort-driven neuroplasticity. Also, I have a number of building brain awareness talk series where this gets into in one form or another. But there are other ways to improve brain injury problems, and this is important too. Some examples in the podcast that I've discussed with other people include the overall benefits of exercise, the prism lenses, and other treatments that are out there, that these do involve effort and they do involve change. There's a number of building brain awareness talk series about this with alternative therapies, EMDR, and the sensory learning talk that I had just mentioned. And these, although these don't have the effort-driven neuroplasticity, they do affect and help the brain in other ways, and they change, the neuroplasticity of the brain, and let's say in other ways. So these are important therapies and treatments and ways that I just wanted to mention as well. In my experience, I had these additional ways to promote neuroplasticity, and this is what Jared had spoken about: sleep and rest, exercise, diet and nutrition, and finding social support. And I look at it as validation for our brain injury problems, because otherwise you're in isolation. And I felt like for 17 years no one would ever understand what I was dealing with, and it's really a horrible place to be. Brain injury problems feel so large and overwhelming that sometimes it's hard to decide, oh, well, I also need to go to the gym, or I also need to eat better because I'm dealing with this much bigger issue of brain injury. However, it's important to shift that thinking, at least I think, to help overall. Taking care of these factors will contribute to the benefits in the long term, the benefits of the brain in the long term. So that's why these factors are actually very, very important. So going back to thinking about how to promote neuroplasticity and that improvement over time. So it's easy to think about brain injury problems as very different. Movement, cognition, speech, all these different problems, they look like, such different processes within us. But if their problems are due to injury to the brain, then I think there's actually a lot of similarity in terms of what can be done to work and improve and regain each capacity over time. And in my experience and observation of others, I think the neuroplasticity can be promoted and worked on in these similar ways, with working in very, very small steps. That's what I call baby steps over time. And this effort, sometimes it starts at a tiny scale where you've almost done nothing. And in my experience, the self-doubt and beating yourself up for doing almost nothing, because you feel like, what did I just do? But in fact, it's very difficult to do that tiny step. Repetition and support are key, and support can have different forms. Progress is also very slow, and it's very difficult to do these efforts. I mean, these are the things that got injured in us because of the brain injury. So I think this has its own relearning curve, and I've never really been able to find that in the literature. Much is still not known about this process. Although there is a lot of research out there, there's still a lot missing in terms of neuroplasticity with brain injury. So how to promote neuroplasticity after brain injury? I see it as the neuroplasticity is necessary both for the right steps to improve in small baby steps over time. Also, the support needs to be there for the setbacks and for the downward spirals, because you need to have the right support so that you don't even get into the downward spirals and have the overwhelming problems take over. Those problems need to be supported enough to be able to do the work to improve other things. One more podcast I wanted to mention, and I don't have an excerpt here, but it's a really fascinating discussion I had with Tanya. And she was a person, because of her profession, she learned how to not push herself to the limit. And she was very good at that, learning to not aggravate the brain injury problems. And it led to a lot of improvement. And she didn't even do work to improve what she had injured. She just learned how to not push herself. She describes these jump points where in every 6 months, things would just come back in these very specific stages. I had the same experience. I called it leveling up. It took me 4 years to realize to not push myself to the limit. And after that, I had these leveling up experiences. And the discussion with her, I think, was really fascinating because I haven't found too many people to talk about that kind of feeling inside yourself. But I have seen other people talk about it with brain injury. That's it. If you have any questions, I think I'm open to discussion, and I'm going to stop sharing this. There's a lot of content between my presentation and Jared's, but I'm trying to focus more on the brain injury side of things. And both of these will go out. I'll put them out on YouTube. Looking at the chat, yeah, major setbacks. I've spoken to, I had a 7-year rebuilding with many setbacks in it, and I wish I've only heard brain injury people talk about setbacks. So it's something that we need to let people know that this exists. Yeah, the gaslighting. I never met an expert that knew what I was dealing with. It drove me crazy. At best, I had two clinicians that knew about the things that they were experts on. But as soon as you go outside of that scope, there was no help. And it was almost like I had to learn to not talk to them about anything except for what they learned. Or what they knew. So I still find that to be the case. I think Jared is one of the few highly aware of brain injury problem examples, but maybe he works with a good team, but I haven't met many people in that situation. So
I have a comment about setbacks. It's just short. My thought is it's hard to talk about setbacks because a setback for me takes me to a place where I can't talk about it. I can't think about it well enough to articulate it. And so it's extra invisible.
Well, in a setback, I was in the same situation, and then I know you, Nancy, and we can share that I had the supports enough that there was a safety net to rebuild and regain. And it's like I have to go into this hole that I can't function and then slowly crawl out of. If I didn't have those supports, then I can imagine that I might have never gotten out of that, or it'd just be very, very hard. So yeah, it's super hard to articulate, especially when you're in that situation. And so sadly, the nature of the setbacks is somewhat similar across brain injury people, and what sets them back can be all kinds of things. Yes.
I wanted to say one other thing. Your the your new graphics and your way of talking about this that
Yeah.
we've discussed over the years, I'm so impressed. I love the way it's coming together. Your analogies and your images. Yeah.
Um, Thanks for saying that, because these images come from my experiences and almost like a caveman drawings of what's the point here, and then making it look nice. So
The
yeah.
spiral down, the trapdoor, the quicksand. It's good.
Well, I'd say hundreds of experiences across each of these, and then talk to enough other people about it. I go, this is similar. These are parallels. Thanks.
I have one thing I'm curious about. It's Rachel.
Hi, Rachel.
Hi, Scott had a good question. Like he said, how do you know if you are actually building neuroplasticity through all this effort? Is there a way to measure it? Like I know, yeah, it's interesting because like when they did functional neurology, they have their ways of measuring it, you know, in clinic. But then I too wonder, like, how is there a way to measure it? Like even not in
Um,
clinic?
yeah, I would say, first off, good question, and I'm sorry I'm not able to monitor the chat right now. I'm kind of a little bit too much, but no, which makes it really hard. And in my experience, it's like you're walking blindly into this process. I can share two examples that with my double vision, I was given all these exercises to move my eyeballs that eventually restored the vision. And it was like, what the hell happened? It was so bizarre. the rebuilding in that stage was so weird. That's kind of why I get into all these core problems, because there's like this invisibility to them. And then in the cognitive rebuilding, very, very basic addition and subtraction over time led to the ability to do one step higher math. And before that, when I tried to do that, I would hit this fatigue where I would just be in bed for days. So I have not, in my experience and observation, I've not found a way to know that, but I believe that I kind of learned how to trust the process, and then with enough of these tiny efforts, there would be a smaller increase. But perhaps there are ways out there with the right clinician, neurofeedback, and other forms. But really, I had to see it to believe it in terms of these baby steps. What's his name? There's one talk in my series where the clinician describes a computer adaptive test that he's used to measure this, and because it's computer adaptive, he's monitoring what the person is doing, and then the program is changing and building in a baby step form. So I believe, since he has a computer adaptive way to assess this, there are markers, there are ways to test this, but in my experience, it was like you're walking through a fog for a long time. So I don't know. I never found anything that was helpful in that way. And the delayed gratification of this makes it even harder. But yeah, I can share that talk later, and it's in my list of the
The other problem in my mind,
Jerry Vogel. He has, I believe he has data that is collecting that. So I think there are cues out there. I just don't know what they are.
the other problem in my mind about those assessments, because I've had so many very non-useful neuropsych exams, is they're really not looking at the things that are happening. So they're latching onto markers, but they may not be meaningful in the individual being assessed.
Well, yeah, I'm still waiting on the first talk in this series this year was about the frontal lobe paradox, which is the clinician's term for what it's a paradox to them that we have problems that aren't on their assessments. But what you just said is they're not even aware of what we're doing. So going back to the feeling and being aware of the neuroplasticity, if your efforts are so tiny that if you can do this and then you can do the next step, which are both very, very small efforts, like Steve, in the talk that he gave, he describes the crawling progression and him using crawling and just scooting around his house to be able to do the basic functions. Because he knew about the stages, I think he could track the progression. So it'd be nice, what are your brain injury problems? How are you able to improve them? The improvement is so small, but my point reminded, but what you said, Nancy, is that we can see that tiny progression because we're aware of it. So maybe that's a way to slowly implement it and have some, feedback or self-feedback. But yeah, it's really hard to do. And again, it's sad that we're sort of more on our own with this than is optimal.
Can I mention one more thing, Dan? It's
Yeah, yeah,
Rachel.
yeah.
So in the talk, it talked about prism lenses, and I just kind of almost have a question. I've had prism lenses before, and I'm sure maybe a variety of us have, and they do seem helpful. But then there was one professional that told me that specifically for my case, maybe I don't want to use prism lenses because, what's going on, I guess, with my eyes and brain. Then when I take the prism lenses off, I'm going to be so disoriented. And it's just interesting that the prism lenses came up today, and because I have been considering going to Mind Eye Institute because I'm not that far from there. And I just wonder what other people's thoughts were on prism lenses, or your thoughts on prisms.
Yeah, my thoughts are, and listen to that recording with Linda because she has a great example of it. But I think of it as this hierarchy of problems, the vision problems and certain vision, vestibular movement, that those are really dominant issues that I think need to be dealt with earlier than the later issues. With my double vision, I couldn't even get into the cognitive stuff and realizing that my mind was not my mind until I dealt with the vision issues. And that took over a year. but it was really hard to do. I didn't have the lenses. The lenses I look at as semi passive. You know, you're putting it on yourself, but it changes your brain. And I've spoken to enough people about how hard it is, but I think it leads to an overall benefit that with enough of that being better, then another issue can be dealt with. So that's what I mean by a hierarchy. But if it's too much, then maybe not. Yeah, Nancy?
I have a perspective on it simply because I did try it for a little while. And first of all, my thought is if it helps some of the time, hooray, because otherwise we're disoriented all the time. um, but for me, my experience with the prism glasses, it didn't feel passive at all. It felt like really hard work. It took a while for me to gear up to being able to wear them. And then I stopped using them, and I don't think I fully regressed, but they weren't useful anymore, but I continue to have visual problems. And I have talked to the Mind Institute, like I wanted to go there. For me, it wasn't affordable. And though wow, if I lived nearby, Rachel, I would try and figure out how to go though.
Thank you.
Yeah.
I've had different discussions with people about sometimes the lenses they get are causing too much problems and they can't function otherwise. Sometimes they have the room to allow for that, and it takes a long time and a lot of discomfort, but eventually there's a benefit. And they have this progression of lenses and a whole lot of processes there. It's not an easy process. It's a very difficult process. There, I think I've listened to what's the head doctor there, her view of
Doc-
neuroplasticity, I kind of disagree with, because they look at it as just, they look at it in the view of what neuroplasticity is without brain injury. Scott, I saw your comment about the being stuck in the setbacks. Yeah, the being stuck in it, I don't know how to get out of it aside from the long, slow progression of letting the rest, and sometimes you're starting several steps back from where you were. There's some good therapy ideas in the BART talk with hyperbaric oxygen treatment and fish oil, like heavy doses of fish oil that he had learned from military vets using it for brain injury recovery. So I think that those alternative therapies can be used potentially as a support, but it's really hard to be in that setback place. All right. Thank you all.
Well done.
Thank you.
All right. I'm going to go. Bye.
Bye.